Good morning, everyone. I am going to present interesting case number 651/22. History. 20 years old female presented with chief complaint of pain in left knee joint since 6 months, swelling in the left knee joint since 2 months. Patient was apparently alright 6 months back. Then she developed pain in the left knee joint, which was gradual in onset and progressive in nature. Pain was dull aching type and it increased on doing activity. 2 months back, she noticed swelling in the left knee joint, which was initially of the size of lemon and now progressed to the present size of cricket ball. There was no history of fall and no history of fever. Past history, not known case of hypertension or diabetes, no significant family history. On personal history, diet was mixed, appetite normal, sleep adequate, bowel and bladder habits normal and regular. General physical examination, pallor was seen. There were no signs of icterus, cyanosis, clubbing, pedal edema, and lymphadenopathy. Pulse rate 80 beats per minute, blood pressure 120 by 80 mmHg, respiratory rate 18 cycles per minute. On local examination of the left knee joint, tenderness was present, movements were satisfactory, swelling was seen, and no skin changes were seen. Systemic examination. Respiratory system, cardiovascular system, central nervous system, and per abdomen, no abnormality was detected. On complete blood picture, hemoglobin was 10.8 gram per deciliter. Total count, platelet count, and differential counts were within normal limit. Radiological examination. X-ray of the bone of the lesion, bony lesion showed a lytic lesion present on the proximal end of the tibia of the fibula. It was giving soap bubble like appearance. On MRI, here also we can see lytic lesion present on the proximal end of the fibula. So, radiological findings on X-ray was giant cell tumor of bone. On MRI, differential diagnosis as giant cell tumor of bone or aneurysmal bone cyst was given. The patient got operated and the specimen was sent to the Department of Pathology. We have received an irregular grey-white friable mass which was measuring 7 into 6 into 2 centimeter. This mass was cut open and it had a cystic area or a cyst was present which was measuring 4 into 4 into 3 centimeter. One end of the cyst was hard or bony surface was seen, the other area was friable. Coming to the microscopy. This is the scanner view. In the first image we can see on this photomicrograph there are bony trabeculae seen beneath which we can see sheets of cells which are having uniformly spread giant cells along with some mononuclear cells. In the second photomicrograph we can see sheets of giant cells along with mononuclear cells. This is low power image. Again here we can see sheets of cells which are of two types, giant cells or osteoclast like giant cells and mononuclear cells. On higher power or higher magnification, we can clearly see osteoclast like giant cells and mononuclear cells. These mononuclear cells are either round in shape or they are spindly in shape. The nucleus of the mononuclear cells and those of the osteoclast like giant cell is same. Here again we can see giant cells along with those giant cells are mononuclear tumor cells which are oval to spindle in shape. These are the low power photomicrograph which are showing. In the first photomicrograph we can see bony trabeculae along with many dilated and congested blood vessels. In the second photomicrograph, we can see skeletal muscle tissue. So overall, the H&E stained sections of the tumor showed bony tissue beneath which fibroconnective tissue and well circumscribed tumor mass composed of numerous osteoclast like giant cells uniformly scattered with numerous mononuclear cells which were round to spindle shaped were seen. Also seen were dilated vascular channels and foci of skeletal muscle tissue. So, based on these findings, the diagnosis was given as giant cell tumor of bone. Coming to the review of literature, giant cell tumor can be benign, borderline, and malignant. Most of the cases are usually seen of benign giant cell tumor, which will be present either in the epiphysis or in the metaphysis of the long bones. On WHO classification of bone tumors, it comes in the category of osteoclast like giant cell rich tumors. Here we can see it is of three category: benign, intermediate and malignant. Definition: giant cell tumor of bone is a locally aggressive and rarely metastasizing neoplasm composed of neoplastic mononuclear stromal cell mixed with macrophages and osteoclast like giant cells. Epidemiology: giant cell tumor of bone constitutes 5% of all bony tumors, primary bone tumors. Most patients are in the third and fourth decade of life and is usually seen in younger individuals, and those who are less than 20 years will be having a mature skeleton, and most of them are likely to be female. When it comes to male to female ratio, it is seen with a little predominance in female, that is 1 is to 1.38. Median age of presentation is 35 years. In pediatric population, giant cell tumor of bone is seen rarely. There is no difference in localization according to age or sex. Sites of giant cell tumor in bone. These tumor typically involves the metaphysis and epiphysis of the long bones. Distal femur and proximal tibia are the most common sites, but the distal radius and proximal humerus are also affected. In axial skeleton, the proximal sacrum is the most common location, but giant cell tumor of bone can occur in almost any bone, including the small bones of hands and feet and cis-point bones such as patella. Clinical features: giant cell tumor of bone presents with complaints of pain, swelling, and occasionally restricted joint movements. Pathological fractures occur in 5 to 12% of the patients. Vertebral and sacral tumors present with lower back pain, frequent radiation to the legs, and sometimes with bladder, rectal, or sexual dysfunction. On radiological examination of giant cell tumor, the lesions are usually lytic and appear to be very aggressive. Here we can see the lesion is present on the proximal end of the humerus, and in the second photomicrograph it is present on the distal end of the femur, and it is giving a typical soap bubble like appearance. On gross, the lesion is soft and dark brown, and it is usually fleshy with white or pinkish in coloration. Coming to the microscopy, giant cell tumor consists of multinucleated giant cells and mononuclear cells. The giant cells are usually distributed uniformly throughout the lesion. The giant cells may contain as few as 10 to as many as 50 nuclei. The mononuclear cells are round to oval. The nuclei resemble those in the giant cells. Although mitotic activity may be brisk in mononuclear cells, the nuclei lack a tibia. In the first photomicrograph, we can see mixture of mononuclear cells and the giant cells. Second photomicrograph shows a higher power appearance of the giant cells. Along with, we can see the nuclei of the giant cells are similar to those of the mononuclear cells. Immunohistochemistry. It stains positively for H3G34W, P63, SALL4, SATB2, CD68. Negative stain is H3K36M. Differential diagnosis: aneurysmal bone cyst, chondroblastoma, giant cell rich osteosarcoma, non ossifying fibroma. First, aneurysmal bone cyst. On microscopy, it is a multiloculated cystic lesion, blood filled cystic spaces separated by cellular septa containing fibroblast, giant cells, and woven bone are seen. Calcified basophilic material will be present along with necrosis and mitotic activity, which is easily identified. There is no cytologic atypia. In this photomicrograph, we can see aneurysmal bone cyst wall showing lack of distinctive cell lining and composed of spindle cells with scattered osteoclast like giant cells and hemorrhage. Chondroblastoma. This is a tumor which has predilection for epiphyseal region of the long bones. On microscopy, the tumor shows sheets of polygonal cells with small grooved nuclei and eosinophilic cytoplasm, interspread osteoclast like giant cells, and islands of chondroid matrix. Chicken wire pattern of calcification is seen, and on immunohistochemistry it is positive for H3K36M, which is negative in giant cell tumor. In this photomicrograph we can see sheets of chondroblastic oval to polygonal cells, osteoclast like giant cell, and pericellular lace like calcification. Giant cell rich osteosarcoma. On microscopy, it shows neoplastic osteoblast with marked nuclear pleomorphism, prominent nucleoli, and atypical mitosis. Abundant spindle cells with marked atypia arranged in a streaming or storiform pattern. Infiltration of pre-existing lamellar bone structures. On immunohistochemistry, it is negative for Hg34W. This photomicrograph we can see sheets of neoplastic spindle cells with marked atypia and abundant osteoclast like giant cells. Last differential is non-ossifying fibroma. Location wise, it is usually seen in metaphyseal end of the long bones and it is seen in skeletally immature patients. On microscopy, tumor shows storiform proliferation of plump spindle cells, intermingled osteoclast like giant cells, hemosiderin laden macrophages, and cluster of foamy histiocytes. On immunohistochemistry, it is negative for Hg34W. This photomicrograph we can see non-ossifying fibroma composed of spindle-shaped cells arranged in storiform pattern with scattered osteoclast like giant cells. These are my references. Thank you.